All right, good morning, everyone. Welcome to the public presentation of the Business Healthcare Group Physician Value Study 3.0 findings and observations. I'm going to go ahead and turn it over to Lisa Mrzinski to open the meeting and give us some quick thoughts.
All right, thank you, Dave. Good morning, everyone, and welcome. As Dave mentioned, I am Lisa Mrzinski. I'm a member of the Executive Steering Committee for the Business Healthcare Group, and we're very glad you could join us today for this important presentation. We are presenting the results of the third Physician Value Study, which was commissioned by the Business Healthcare Group and completed by ATIA. I'd like to acknowledge and thank Gates Ventures, Centivo, and HPS Paymedics for their financial support of this critical project. Novo Nordisk would also like to thank the Business Healthcare Group and its membership for the opportunity to be our educational sponsor for this event. On the screen, you will see 3 Novo Nordisk account managers for Wisconsin. For any employer on the line, feel free to reach out to them if you have any questions regarding benefit coverage for obesity as you look to your 2026 benefit offerings. A top priority of the Business Healthcare Group and the Wisconsin business community is to purchase high-value healthcare. Excuse me. Unfortunately, even though we enjoy high-quality care with strong access in our state, we also experience high costs with significant differences in cost effectiveness that are not linked to any measurable differences in quality. To that end, in 2018, BHCG commissioned its first study, PVS 1.0, to evaluate the cost efficiency and quality of care provided by physicians throughout Wisconsin. That first study showed substantial variation in the value of care provided and estimated a significant amount of healthcare spending could be eliminated through health system performance improvement. The second study, PVS 2.0, was commissioned in 2021 and produced similar findings. PVS 3.0, again using claims data from the Wisconsin Health Information Organization, has once again produced compelling evidence that there is significant potential for cost savings and better outcomes throughout health system performance improvement. Further, this third iteration of the study has added several additional analyses of the claims data, which we are pleased to share with you today. These results offer a way forward for our organization in conjunction with our strategic partners and the healthcare community to improve healthcare value for everyone. There will be a Q&A session after our last presenter. You may submit questions virtually, and we'll get to as many as time permits. And as always, if you have questions or would like more information about the study results or BHCG, you can contact me directly or any one of the BHCG members. Also, a recording of the slides a recording and the slides of today's presentation will be distributed and available on our website. And now I'm pleased to introduce Marie Foley, Vice President, Provider Relations and Actuarial Services for HP Paymedics, who will share a few comments with you.
Morning. I'm Marie Foley again from HPS Paymedics, Senior Vice President of Actuarial Services and Provider Contracting. I want to take this time to thank BHCG for their exceptional work on the Physician Value Study and the new 3.0 analysis they've completed. Your dedication to leveraging Wisconsin's all-payer claims data to highlight provider performance and value is truly invaluable to the community. I would also like to thank WEO for their dedication to making healthcare both affordable and equitable in Wisconsin and making this data available. I know it takes a lot of time and effort to compile the data. The addition of the social determinants of healthcare data set gives us the power to pinpoint any treatment disparities and begin additional work on that new data set. At HPS, we evaluate our network utilization at the episode of care level to make sure our members can find high-value providers. So the addition of the physician value study data will give additional insights to refine that analysis we do, so we can consistently identify providers exceeding both cost-efficient and quality benchmarks. With Paymedic's single payment model, providers receive the full claim payment, covering both the insurance portion and patient responsibility upfront. So the providers do not need to collect from patients before delivering care. This not only eliminates payment uncertainty for patients, but allows access to care regardless of their ability to pay, and also secures timely, predictable payments for providers. So thank you all providers and employer groups for your ongoing commitment to delivering efficient, equitable, and high quality care. We're excited to build on these insights together to empower our employer groups and patients across Wisconsin. And I'll pass it off to Dave to start the presentation.
Thank you, Lisa and Marie. Appreciate your opening comments. I'm Dave Ostroff. I'm the Business Healthcare Group Strategic Advisor. Have worked with the coalition for numerous years, and I'm pleased to be a part of the conversation. I also serve as the Chief Actuary of the Centivo Health Plan. While most of my comments today will be relative to my BHCG role, I will throw in some health plan thoughts as we go along as well. So as you look at what you're going to see today, I'm going to give you a bit of a grounding and some context for why we did this, what we were trying to achieve, what types of information you're going to see, and what kinds of opportunity may be out there. In particular, the I think foundation of why the Business Healthcare Group commissioned the study in the first place is really important. Part of that is really understanding that when we thought about value for healthcare in the state of Wisconsin, knowing that there was a relatively high quality threshold that had been seen in the past, having some questions about the cost efficiency of care, we really wanted to evaluate that from the standpoint of should employers be taking action steps to really try to encourage and access some of the highest value care. At the end of the day, there were a number of things that we were shooting for, but in particular, creating a collaborative process for the employers to work directly with healthcare providers within the state is something that was really important to us. We felt that there was too much time spent sort of with intermediaries in the middle of that conversation, in a world where healthcare sort of across the U.S. has been relatively inefficiently delivered. I think part of what has happened is a lack of some of the direct dialogue, and the physician value study serves as a way to actually create some of that far more direct dialogue. We want to look at actual performance, not something that's aspirational, unrealistic. So we're looking at a data set that is what has actually occurred, what the art of the possible really is, and looking at taking advantage of some of the better practices that are out there. When we thought about the version 3.0 of the study, and Lisa touched on a few of these ideas, there was no question that we wanted to look at extending some of the things that we had done in the earlier versions of the study, as well as adding new pieces. In particular, we wanted to see if the variation that we had seen in past versions of the study still existed, and what that variation meant in terms of the efficiency of delivery of healthcare services, what we could possibly see in terms of cost savings if we took advantage of some of the better practices. We were also in a position with this version of the study to look at the big picture question of, does physician performance stay relatively consistent over time? So are high performers remaining as high performers? In other words, is high performance sticky? It was one of those important questions to say, if we're going to set up a model that takes advantage of a measurement structure like this, are we subjecting ourselves to a whole bunch of swings year over year, or do we in fact see a performance structure that is pretty consistent over time. We did look at the bigger picture question of social determinants of health, knowing that historically people have pointed to that as a reason for the variation in performance. We wanted to see from a statistical standpoint if that was really true. And so getting the additional data that is available within WHEO around the social determinants of health this time gave us a way to measure that far more directly. And one of the big picture questions that we had is this a study that is something that can be replicated in other markets across the U.S.? You know, we had done it in the past versions of the study for the Wisconsin marketplace. I'm proud to do so. Wanted to really look at whether this is something that could inform a national dialogue, not just a local dialogue. Part of the virtue of having Gates Ventures as the primary sponsor of this study was to add an additional national voice who is really interested in getting this out in the broader marketplace. So we appreciate their co-sponsorship and they've helped us to think about this in a broader context. And we'll talk about some of that in terms of the applicability of the study. As you hear the study results, I'm going to give you a bit of framing and a bit of context for ways to think about what's coming forward. When we thought about the study, we said there's really 4 big buckets that we want to think about. One is that the study has to be done in a way that is, frankly, as accurate and as robust as possible. In particular, that meant making sure that we were using the largest data set available, which in Wisconsin is the All-Payer Claim Database from the Wisconsin Health Information Organization. So, starting with as much data as we could possibly ingest, and then making sure that we were using state-of-the-art tools. This is the kind of study that frankly couldn't have been done, say, 10 years ago, but with the advancements in big data models with artificial intelligence inspired types of machine learning processes, we're able to do a lot more analysis, and you will see, frankly, one of the most sophisticated analysis I've ever seen as somebody who's been an actuary in the healthcare world for a very long time. There's things that we wanted to make sure that we were looking at, and that really meant trying to drive things down to the individual physician level. So when we look at results today, you're going to see results that have been aggregated back up to a certain level. What we really are able to do with this data is go down to the individual physician by physician data. We're also able to take it down into the individual clinical categories and look at what happens when a physician is managing a diabetic, for example, or a hypertensive or someone with asthma. So there is a very granular set of data that sits behind all this. As you see results, we will have rolled those back up into, for example, the various quartiles of performance. So you'll see people in the top quartile, people who are performing the second quartile, people who are in the bottom half of the distribution. It'll give you a sense for how big those different groups are and what the different opportunity is. But as I noted, the data is available all the way down to the individual physician level. And as we have worked with some of the health systems in the state, they've been able to acquire the data to use it in a number of their initiatives. The focus of the study really is to make sure that we are thinking about this in 2 ways. Quality is pretty straightforward in that we're using evidence-based medicine compliance rates. We thought it was very important not to create a brand new quality statistic that people hadn't seen before, but instead to use what has been accepted in the healthcare marketplace, and using the EBM compliance rates was something that was a very natural fit from a quality standpoint. The cost efficiency, because of the need to do things at a very strong analytical level, is something that you will hear about in terms of the methodology pieces and the different kinds of approaches that we took to get the cost efficiency analysis. We had a very important early decision to make, and that was whether we were going to use actual contractual rates and contractual costs for the various services, which really reflects frankly, the purchasing and negotiating power of the different employers that exist in different health systems that exist in networks, or whether we would try to normalize the cost. So that as you're thinking about this, when we talk about normalized cost, an X-ray costs the same on that basis, whether it is provided in a Medicare Advantage plan or in a Medicaid plan or in a commercial plan. And we opted for the latter, that we would use the normalized cost, which allows us to really look at the efficient use of resources by a physician. So in this study, cost efficiency really is all about resource efficiency, not about whether someone can contract at a higher or lower rate as we go forward. And finally, we spent a lot of time talking about the application of the study and what we're going to do with the study results. And obviously that helped inform how the study was structured to be able to say, we're going to spend as much time on the what of the study as well as the so what of the study. So the what you're going to hear from Earl in terms of what the results really are, how they've been developed, what the results are showing us. The so what becomes the question of, okay, once we've done that, what do we do with this actual information? And I will come back and talk a bit about that as we get towards the end of the presentation. With that, I am going to turn it over to Dr. Earl Steinberg. If I gave you Earl's resume, it would take up the next hour, so I will avoid doing that. But suffice it to say, Earl is one of the leading practitioners in the country on physician evaluation, has been doing it in various venues and various kinds of areas for a very long time, does it extremely well. We are privileged to have had Earl's experience and expertise, his commitment to this area, and frankly, his good humor in moving this all forward. And so I'm very pleased to introduce to you Dr. Earl Steinberg.
Appreciate that kind introduction. And I'm happy to present the results of version 3 of the physician value study to you. I'll warn you in advance that parts of this are pretty dense, and particularly in the case of some of the methods that we employed, many of you won't be familiar with those technical things, but I'll try to keep it as simplified as possible, and I welcome any questions anybody has during or at the end of the presentation. I want to acknowledge my colleague Nathan Kleiman, who's a biostatistician epidemiologist who worked with me on the analysis of the data. This largely repeats what Dave said, but I want to highlight a couple of things. The first is that we didn't just look at the performance of primary care docs. BHCG selected 11 high volume procedures that are typically performed by specialists rather than primary care docs. And we'll show you the results of the cost efficiency of those specialists and performance of these 11 high volume procedures. Dave alluded to the fact that as in the earlier versions of this study, we used a special type of machine learning to estimate how much money could potentially be saved if physicians who were in the bottom half of the distribution of cost efficiency were able to improve their performance to the 50th percentile. And those results are interesting. They're consistent with past estimates, and they are consistent with estimates from other studies on other populations of patients and physicians. And finally, I just want to mention that BHCG asked for version 3 for us to try to identify what accounted for the differences in observed cost efficiency. In other words, what were the drivers of those differences? That's a question that is impossible to answer definitively using claims data alone. I think chart review and review with physicians themselves is necessary, but we took a crack at it with claims data, and our hope is that the findings will provide some insights that might guide efforts by provider organizations to dig further into what the drivers of these observed differences in cost efficiency are. I'm going to start out with a handful of slides that highlight sort of the headline results. And then I'll go into much more detail, not only on those results, but on the methods as a whole and the spectrum of quality analyses that we performed. What you see in this slide is a scattergram along the horizontal axis at the bottom are cost efficiency scores. And as I'll explain later, a score of 0 represents that the actual cost of caring for a particular patient and your entire panel of patients was what was expected based on consideration of all of those patients' attributes and risk factors. A score that is to the right of 0, in other words, is positive, it indicates a performance that was better than expected. And similarly, a performance score to the left of 0 represents cost efficiency score that was worse than predicted. On the vertical axis are quality scores for the same physicians. Quality scores ranged from 0 to 1. A score of 1 meant that a physician delivered every service that would be expected based on predominant evidence-based clinical practice guidelines. The lower the score indicates the lower percentage of instances in which a physician complied with an evidence-based guideline when that evidence-based guideline applied to their patient. Dave referred to, 4 different quadrants. The lower left quadrant, those dots represent physicians whose cost efficiency score was worse than predicted and whose quality was less than 50%. So ideally, what one would want to do would be to move all of those physicians into the upper right quadrant, if possible, and ideally everybody would be in the upper right quadrant. I want to mention that the correlation between quality and cost efficiency was virtually 0. And that may surprise you. You may think that doctors who are more expensive to see in terms of their resource use provide higher quality care. That's not the case. And this is not just a finding that came out of our study, but in the literature, there are multiple studies that have looked at the correlation between quality and efficiency, and they have observed exactly what you see here, 0 correlation. This slide, a little complicated, but I'll focus on the main points. This slide shows the amount of annual savings that we estimated reaped if every individual PCP and specialist whose cost efficiency was less than the 50th percentile instead performed at the 50th percentile. Our reasoning was that we didn't think, performing at the middle of the pack was too much to expect. As you can see, when there were $614 million in this iteration of the study that we estimated could be saved when looking at PCPs, and there was $655 million that we estimated could be saved based on only 11 specialty procedures. No, those were the average annual total cost estimates. So I apologize. There was $288 million that could be saved from PCPs and $106 million that could be saved in the case of the specialists who performed the 11 procedures we looked at. So in total, $394 million per year we estimated could be saved just by looking at the things that we looked at. And that represents 31% of the total cost. In the next line, you see the results from version 2, where the total estimated cost savings potential was $378 million, so very similar, 25% of the total cost. These numbers, again, should not surprise you if you're familiar with the literature in this area. There's quite a substantial literature that estimates, based on data analyses, that about 30% of what's expended on healthcare in the US is unnecessary or outright harmful. So this number is consistent with that. I found an article that I thought was interesting that was a survey of physicians in which the physicians were asked, what percent of total cost do you think are either unnecessary, inappropriate, or outright harmful? And their estimate was 33%. So physicians are aware of the fact that a substantial amount of care is not necessary. And when they were asked, why they came up with that estimate, they referred to a number of things. Number one was medical legal considerations. But anyway, this is not a number that's inconsistent with other publications. This is a complicated graph. And I'll try to walk you through it. I don't have a pointer, but if you look at the bar on the far left, those are docs whose quality score in 2018-19 was in the top rank. And I'll explain what that is. I'll show you later, but basically we were 80% confident that their performance was better than 0.5. And what the different color bars show is that of those docs who were rank 1 in 2018-19, the green says that 57% of those docs were rank 1 in 2021-2022 as well, and an additional 28% were in rank 2. And on the far right bar, those are docs whose performance on quality was in the bottom rank 4. And of those, 73% continued to be in the rank 4 in 2021-22. So using Dave's words, there was stickiness. These findings are at the individual doc level. So we're not looking at the PCPs as a whole. We're looking at Dr. Jones and what was Dr. Jones's performance in these two different time periods. This is, again, a quote headline slide. I don't want you to worry about the details. I'm going to show you a lot more about this later, but this shows results on the social determinants of health for something called the Area Deprivation Index, ADI. And the ADI is a highly regarded measure of neighborhood disadvantagedness. That's a word. And the higher the score, the more disadvantaged that census tract is. And on the x-axis here, the horizontal axis, you see different groups of docs in terms of their cost efficiency score. So the ones on the leftmost bar are the ones who are most inefficient, and the ones on the right are the most efficient. And I was very excited about the fact that WEO had access to some social determinant of health data, because I have always believed that physicians' concerns about differences in social determinants of health between their patients and other doctors' patients was an important issue, but we didn't have data to measure it. This graph that you see basically shows there's no variation in the Area Deprivation Index national rank across, regardless of whether you have a low or a high cost efficiency score. This really surprised me. And I was scratching my head a lot about it until I was able to dig into it more deeply. And later in the presentation, I'll show you what I think accounts for this lack of variation. Okay, now to the densest part. A review of the methods that we employed. And as I said earlier, I'll try to make this as simple as possible. First, about the data. As you've heard, our source of data was WEO. And the data set we had gotten from WEO had data on 5.36 million residents of Wisconsin. So quite a substantial database. We had information on the type of insurance that people had. And we had data on people with commercial insurance, self-funded employers, Medicaid or Medicare Advantage. Two things of note. One is there was no data on patients with traditional Medicare fee-for-service, and there was no data on patients who had zero insurance, who lacked insurance, which is one thing that may have contributed to that lack of difference in cost efficiency based on SDOH. The data that we had, I'm going to go into more detail about the specific measures, but the data set from WEO is a very rich data set. It had information that would enable someone who had the keys to identify who the exact patient was, who the exact physician was, patient's age, gender, and the insurance claims had information on patient diagnoses, all the inpatient and outpatient services that the patients receive, and as I said, the information on SDOH. Now, it's important to highlight that the data we received from WIO was grouped into what are called episodes of care. And that grouping was performed by Optum, which is part of United Health. There are a number of proprietary episode groupers. And what a grouper does is it looks at each individual insurance claim and it assigns it to a particular episode of care. So, for example, an episode might be somebody who underwent a total hip replacement, or it could be a patient who had diabetes with relevant comorbidities and complications, or without relevant comorbidities or complications. And as you'll see, there were many ETGs, episode treatment groups, that Optum employs. And each ETG is for either a procedure, a chronic condition, or an acute condition. In addition, Optum provided a score of each patient's severity of illness. This again is a proprietary score. I don't know all the details, but its intent, its purpose is to capture differences in patients' risk for different things occurring, complications, for example, based on severity of illness. Next, they provided information on something that they call episode risk groups. And these ERGs estimate the expected cost for each patient based on all of the prior things that I've just described. In this study, we employed each of these things, including this ERG measure, but we also employed a measure based on a very sophisticated type of machine learning, which I'll discuss later. And patients or physicians' cost efficiency score was based on the difference between observed cost for a patient and the predicted cost. And finally, there were these evidence-based measures that Dave referred to. I'll talk more about them, but these are evidence-based guideline based quality measures. So these are based on large randomized trials, and these measures come from a variety of entities, including National Committee for Quality Assurance, CMS, et cetera. As you know already, we looked at calendar 21-22 for the data, and in order to be included in the study, a patient had to have had both medical and pharmacy benefits throughout that entire time period. And finally, we only included episodes of care that were completed and were not outliers, and that finally met criteria that we imposed to try to increase the reproducibility of our findings, the reliability of the findings. The reason for focusing only on episodes that were completed, episodes of care have different duration. For example, an acute episode might have a 30-day observation period. A chronic episode would have a full year time period, and a procedure might have a 90-day period of observation. And we didn't want to include patients where the first indication that the patient had a particular disease was observed, say, in November, and there wasn't time to observe the entire episode, or if a procedure was performed in December and there wasn't time to observe the full 90-day period. Outliers were determined by Optum, and there was a flag for them, and they use pretty standard approaches to defining outliers. And these were, observations way out at one end of the bell-shaped curve, and they were excluded, as is often the case, in order to not distort the main findings. And as you'll see, as I'll explain, we imposed fairly rigorous criteria about the number of episodes of care that were required in order for us to use a particular measure, EBM, or to use a particular ETG. So we didn't want to look at things that occur very infrequently, because in those instances, the confidence interval around the point estimate that we calculate is much larger, and we tried to minimize variation that was related to sample size. Just a couple words on the SPOH factors, characteristics that we looked at. The social and ecological risk factor is what is at the data in the WEO database actually includes, and it looks at patient income, patient education, whether or not the patient is employed, and whether or not the person has good or bad housing quality. And we also got data on race from these SPOH data, which typically don't exist in ordinary claims data. This is a busy slide. The main point of it is I found an article from last year in a journal called Health Affairs. It's a very highly regarded, peer-reviewed journal. And the authors described the area deprivation index as the most heavily independently validated scientific tool for looking at U.S. neighborhood level disadvantage that exists today. And I should point out, given that we're in Wisconsin, that the ADI was developed at the University of Wisconsin. And so we thank them for that. Okay. Pause why. Let's look at the criteria, eligibility criteria that we imposed. So first, PCP eligibility. In order to be included at the quality analysis, a PCP had to have had at least 30 episodes of care from ETGs for which we observed at least 500 episodes across all the docs. This requirement of at least 30 episodes is at the high end of what is often an eligibility requirement, and again was done to increase the reliability. And finally, a PCP to be included in the quality analysis also had to have had at least 100 observations across all their patients on EBM measures related to an ETG that we felt it was reasonable to assume a PCP could be responsible for. And the we is really me, that I felt they could be responsible for. I'm a PCP myself, and so we wanted to look at things that were sort of garden variety things that PCPs see and care for frequently, and not rare diseases or things like that that are more appropriately handled by a specialist. And as I mentioned, the EBMs reflect a variety of national measures. The quality score that we calculate is pretty simple. I think of it as a batting average. So if you think in baseball, if a batter has a 300 batting average, that means that every 10 times they're at the plate, on average, excluding walks, they get a hit 3 times. So 30% of the time, they get a hit. Similarly, the quality scores that we looked at are a ratio where the denominator of the score, the number of instances in which a particular EBM applied to one of their patients. The numerator is of those instances, how often did they do what the EBM recommends be done based on evidence, what is best practice. So a score of 0.3 in terms of quality is not as good as a batting average of 300, because it means that the doc only did what's recommended 30% of the time. And then finally, we calculated a weighted average of these ratios, where the weight was the proportion of a doc's patients to whom each EBM applied. So there was a score for each measure, and then we took a weighted average of those scores. Attribution of episodes to PCPs is an important issue. How did we do that? We used what Optum provided to us, which was that something that's commonly used. So the attributable doc was the doc who was responsible for services provided that had the highest sum of cost for that patient. So in the case of patients who saw more than one physician who was a PCP, we only looked at the physician who had the highest proportion of the cost overall for that patient. Measurement of cost efficiency was a lot more complicated. I mentioned early on that Optum has defined a lot of ETGs. In fact, they have defined 2,760 ETGs. And those are the types of things that I mentioned, like a diabetic without comorbidity, without complication, or a diabetic or a patient with heart failure who had no comorbidities and did not undergo surgery. Things of that sort. Out of that almost 2,800 ETGs, we looked at only 114 ETGs. And those ETGs were based on the fact that we required that, in addition to me thinking that that the ETG was something type of patient that a PCP would frequently manage, there had to have been at least 500 episodes of that particular ETG across all the docs in order for it to be included. And as was the case with quality, in order to be for a PCP to be included in the cost efficiency analysis, they had to have had at least 30 episodes of care from ETGs with at least 500 episodes. And I've already discussed about the outlier bet. All right. Attribution was done similarly as was the case for quality. Now we get a little bit more complicated. For every patient, as I mentioned earlier on, we estimated the cost, annual cost, using a very sophisticated type of Bayesian network inference, which is a particular type of machine learning. And the type that we used is something called causal learning. There are many types of AI, this one differs from the most common ones in two regards. It is able to identify causal relationships between two variables rather than just statistical associations. And finally, it enables you to do simulations to answer what if type questions. And we use this not only to predict cost, but we use this feature of simulations to estimate how much money could be saved if the docs in the lower 50% of cost efficiency scores instead perform at the 50% percentile. Now, I work for an AI company as a consultant. They use this causal learning, but they didn't invent it. It was invented by a professor at UCLA, very sophisticated mathematics, and he won the Turing Award for it. And the Turing Award is considered the Nobel Prize in computer science. Three of the last four Nobel laureates in economics have used this type of causal learning in their research. All that the company that I'm associated with did was take this mathematics and put it on a platform that would enable it to be applied to very large data sets, such as the one from WIO. But this is not a type of machine learning we made up. It is very highly regarded and won this Turing Award. And I think I mentioned this earlier, that every episode had to have started and ended in a particular year, or started in one year and ended in the other, but we had to have sufficient observation time to complete the episode. Okay, this is a simple bell-shaped curve that shows in a little bit more detail. This is a hypothetical distribution of cost efficiency scores. A score of 0, as I mentioned earlier, indicates that actual costs were equal to predicted costs. If actual costs were less than predicted, you got a positive score and we're at the right-hand side of this distribution. If actual costs were more than predicted, you were to the left of 0 and had a negative number. Okay. Anybody have any questions on that? I just want to make sure everybody understands where these quality scores and cost efficiency scores came from. Okay, let's jump into the results. This slide provides information about the PCPs and the patients included in the analysis. As you can see, there were 4,196 PCPs included in the analysis. The most frequent type of PCP was family medicine physician or an internist, and next was pediatrics. And then the numbers for these other types of PCPs got pretty small. There were 912,235 members or patients included and over 1.6 million episodes. The mean age of the patients was about 33, and the gender was a little bit over half were female, 55%. At the bottom, you see that 38% of the patients in the analysis had commercial insurance. 54% had Medicaid, and 8% had Medicare Advantage. Frankly, I was surprised that there was such a high percentage of Medicaid patients. And Dana Richardson, who heads WEO, let me know that at the time period that our data came from, included period with COVID being prominent, and apparently in the state of Wisconsin, or maybe it was national, I don't know, but you couldn't kick somebody off of Medicaid during this time period. So that probably drove up the numbers and in Medicaid, and it probably also contributed to the comparatively low average age of the patients. And finally, on average, each PCP had 266 people who they were responsible for. Okay, this is an important slide. This gives you more detail about the information regarding SDOH that we for the people in this population. You see that the mean score for patients was 57.7 in terms of the national rank of ADI. And remember that I said the higher the ADI, the more disadvantaged the population. And What this 57.7 means is that this was not a highly disadvantaged population of people as measured by the ADI. About 80% of the people were Caucasian, and you can see the percentage for other races. African American was 10.8%. I don't know what it is on average in Wisconsin. The median family income was $76,000. So again, an indication that this was not what you might consider to be a highly disadvantaged population. And 53% were employed, and these two things really stuck out for me. 89% had a computer in their household, and 81% had broadband internet. Again, in my view, indications that this was not a particularly disadvantaged population. And I think this helps explain why we observed no relationship between SDOH using the measures that we employed and cost efficiency. Okay, drilling down now to the individual physician level. In the upper right, you see the distribution of the quality scores. And you see a tail on the left that goes pretty far down in score, representing, particularly low quality scores. And that tail on the left was higher in this version of the study than we observed in 2018-19. And you can see that there were 21% of docs who we considered rank 1, which meant that we were 80% confident that those providers performed better than the 75th percentile. And there were 46% in rank 4, which meant that we were 80% confident that their performance was worse than the 50th percentile. And you see the particular EBM rates a little bit better at the 25th, 50th, and 75th percentile, the upper left, where you see the whole distribution on the right. Okay, I explained this slide earlier. I'm not going to spend much time on it, except to remind you that it shows that there was considerable consistency over time in the physician-specific quality scores between 2018-19 and 21-22. And you see that, for example, in the far right, of the docs who were ranked 4, meaning we were 80% confident that their score was in the lower half of the distribution. They remained in that rank 4 73% of the time in 21-22. Okay, these are data on the cost efficiency scores. The definition of these ranks is exactly what it was they were previously. And you can see that the rank 4 had 34% of the population, and rank 1 had 14% of the population. So for a minute, hold on to those two numbers, 14% rank 1 and 34% rank 2. This shows that there was some slight improvement in cost efficiency over time, but it wasn't much improvement. And this shows the results adjusted for differences in all of those social determinants of health. And you see here that, as was the case without the adjustment, 14% of the PCPs are in rank 1 and 32% are in rank 4 instead of 34%. So again, adjustment for differences in SDOH as measured by the data from WIO and for the population we looked at, it didn't have any meaningful effect. And I'll just run through a bunch of these. I showed this in one of the highlight slides. Again, that in this ADI national rank on the right, you see there was, virtually no difference across the various scores. You see that there was very little difference in terms of race, and I'll show you another slide of this, but you might note that patients who were in the docs who were in the lowest 50th percentile of cost efficiency had the fewest African American patients. And here's the data for individuals who were Caucasian and the percent of households with broadband internet. So I don't know whether Wisconsin provides broadband internet to everybody, but they don't where I live, in Maryland. So this is very high percentage and very little variation. Here you see some data on education worse than 9th grade and percent of the people who were employed. And again, virtually no difference across cost efficiency score. Okay. In this slide, overall, if you look in the upper right, the part that's bolded, if everybody who was in the bottom 50th percentile improved their performance on cost efficiency to the 50th percentile, $577 million per year would be saved. This is same type of estimate, but taking account of SDOH, and instead of 557 or whatever it was, 577, here it's 553. So again, no impact. All right. Dave, in fact, was the person who asked us to look at differences in patterns of practice that might differentiate higher versus lower cost efficiency PCP. So we made an effort to do that. As you've heard, we only had claims data. You can't do this analysis in a definitive way from claims data only. You really have to dig into patients' charts. So you might think of what I'm going to show you as, potential indicators or pointers where at things that if you were a medical director of a health plan or a health system, you might focus more deeply where there's most difference observed here. So the way we went about this, we used 7 standard cost categories based on the type of service that was provided. And you see those on the left. These are standard things that people look at. They're things like radiology, pharmacy, hospitalizations, specialty care, et cetera. And then I picked 5 ETGs that I thought represented patients who had common conditions that might be associated with variation in resource utilization. And those were adult rheumatoid arthritis, asthma, heart failure, diabetes, and high blood pressure. Okay, let me explain this slide. This slide is for patients with high blood pressure, hypertension, and it shows for each of our ranks, rank 1, 2, 3, 4, how much was spent on particular type of services. So you see there actually were no hospitalizations for patients who just had hypertension. And there was little variation in pharmacy or specialty care. And you probably grudgingly conclude that there was a little bit more primary care provided in the rank 4 docs. In other words, they saw the patients more frequently. This would not be a condition that I would drill down on in the chart if I were a medical director, which again, Dave calls these breadcrumbs. Is this a breadcrumb that would lead you to look into hypertension more deeply? And my conclusion would be no. This shows the same, but for asthma. And docs whose patients went to the ER more frequently tended to be in the bottom quartile. There was a little bit more specialty care, little bit more primary care, and a little bit more pharmacy care in rank 4 than rank 1. So this would be something I would drill down further. There might be, some meaningful findings. Adult rheumatoid arthritis, and the main driver here is, in my opinion, pharmacy. The biggest difference between rank 1 and rank 4, and there was also a difference in specialty care between rank 1 and rank 4, and the rank 1 docs tended to not send their patients to a rheumatologist as often as the rank 4 docs. Here's for diabetes, and here's a big difference in pharmacy, and also a significant difference in specialty care. So again, I would look into this. And finally, I think this is the last one, heart failure. Big difference in hospitalizations, big difference in ER, pharmacy, et cetera, as you see here. Now, the difference in ER and hospitalization, potential explanations that have nothing to do with how sick the patient is. One is ER use tends to be higher the more limited office hours that the physician has. If I were betting, I would think that that's what accounts for this. And inpatient, I would suspect also is driven by there wasn't after hours access to a physician or a nurse practitioner who works in that physician's office. Okay, we're getting there. So it's cost efficiency. BHCG selected these procedures to focus on, and I selected what type of docs we should look at for each procedure. So, for example, in the case of back surgery, number 9, we said that could be performed by either a neurosurgeon or an orthopedic surgeon. And deliveries of various types could be performed by either an OBGYN or a family physician. So these are common procedures, and which was the intent, high cost common procedure. So this was the same information, but the number of providers and what the total 2-year cost was for each of these. So for example, there was $62 million expended on cataract surgery, about $90,000 on cholecystectomies, $190 million on vaginal deliveries by OBGYNs, etc. In total, $1.3 billion over the 2-year period. And this shows a distribution of the cost effectiveness scores for these specialists. So I'm going to quickly go through for each of these procedure type of physician combinations, what we observe. So in this case, this is vaginal deliveries by family medicine docs, and 8% of those docs were in rank 1 and 30% were in rank 4. There's for C-section by family medicine docs, 10% in rank 1, 32% in rank 4. Here's for hip replacement, 13%, 27%, and 1 and 4 respectively. And just quickly, all these slides are going to be available to you on BHCG's website, so I don't need to read what's there to you, but you get some sense. Okay, so what do I conclude from the results of this analysis? First, as expected, there continues to be considerable variation in both quality and cost efficiency of PCPs and cost efficiency of specialists who perform high volume procedures. This variation in practice has been observed. First paper on it was in 1971. So it's been going on for a long time. The fact that it persists today is, something that I think is disappointing. There's considerable room for improvement. For example, we're 80% confident that almost half of the docs had a quality score less than 0.6. In other words, they only did what's recommended 60% of the time. As we've mentioned several times, adjustment for difference in race and SBOH had negligible impact. We estimate that if the docs in the lowest 50th percent instead practiced at the 50th percent, 31% of cost, which would equal 394 million, could be saved. And we have observed some differences in types of resource utilization that provide some food for thought and some direction for medical directors who are interested in drilling down further into the medical record. I'll turn it back to Dave. Thank you for your patience. Assuming you're still there.
Thank you. A lot to unpack in that. Obviously, a tremendous amount of information analytics results that came out of this. And you know, we do look at opportunities to share this at levels that allow for use to the maximum extent possible within the healthcare community and the employer community as well. Just a quick reminder, to the extent that you have questions, please put them into the chat and we will address them in the next section. I'm going to flip to sort of the next big element of the conversation here, which is really, so we've got really good information. We've got, you know, a great set of analytics. That's always a good starting point. So we've got the what. Now we need to get to the so what. And really that comes down to a question of how are we going to use these results? What kinds of opportunities have we created? What's the best way to take these results and really make them into a you know, living entity that can help really address our desire, a shared desire, I think, across all the stakeholders for greater value healthcare. And when we look at that, I think it really comes down to three big buckets. One is the ability to use this information in collaborative discussions between the employer community and the provider community. I think, you know, too long we've had sort of a barrier between those two where they've been working in you know, opposite ends. I think there is a lot of opportunity for collaboration. We've already started to see that in many ways in the Wisconsin market, where BHCG has facilitated quarterly meetings with a number of the health systems in the area where we have significant populations in the BHCG Centivo High Performance Program. That has created, I think, a really good back and forth that is sometimes missed. You know, the employer community really hasn't had as a great an ability to talk directly to healthcare systems and healthcare leaders. So, you know, we'll kind of dive into that a little more deeply in a second. I'll also talk about the fact that I think this gives you the opportunity to start to incorporate additional information into continuous improvement models. I think Earl's last section where he talked about the different drivers of variation clearly are, you know, starting points for a lot of that. And we think that's really could be effective. We'll also talk about what it means from a program design standpoint, and the way employers have put together their programs, both from specific plan design issues and programmatic operational elements, but also in terms of what it means for potential payment models and how we change and move away from some of the traditional fee-for-service transaction-based payment structures into those that really do reward value in a different way. Finally, we'll talk a bit about, you know, the fact that this is a study that is intended to be more broadly disseminated, and some of the different venues that we'll be talking about doing that in, might probably be worthwhile for you all to have some awareness of. You know, coming back to that whole question of collaboration, I think the thing that we have found is that getting parties together in a room can create some probably very useful synergy. It has been, somewhat unusual for the provider community to be able to come back to the employers and say, we could do better work, we could have better outcomes, we would have a more effective structure if. And a lot of that historically has come back to, if you as employers didn't simply structure your benefit programs in a way that said to people, go get care anywhere, anytime from anybody, and instead created a little more a set of guardrails around it, allowing provider community to take greater accountability. So that has been a important piece of the dialogue. I think this kind of set of results and sort of the trade-off of, if you give me the ability to do better here, I can improve my results over there, is something that really is an opportunity not to be missed at this point. Obviously the very direct taking this data and looking at the variation and what creates variation and looking at, individual practitioners side by side gives you a level of comparative analysis that is often not available. Having the ability to focus on resource efficiency as the measure of cost efficiency, I think is incredibly valuable. Physicians have historically done a very good job of focusing on quality and trying to understand, some of the quality elements. Obviously, we'd like to see that continue to advance and look at higher rates of things like EBM compliance, but we have really struggled to get to the economic of the delivery of healthcare. Frankly, haven't trained for that in our medical schools. We haven't been able to do as effective a job of that in our day-to-day work. We've had times where, the less efficient a provider is, actually the more revenue they generate, and that isn't probably the right outcome. So looking at ways within, the structures that create some of the continuous improvement models in health systems and physician practices to incorporate the economic efficiency elements that are provided in a study like this can be really beneficial. I talk about it from a program design standpoint. I think a number of you have seen the BHCG Centivo High Performance Program that has been in place in this market since 2022. Part of the key decisions made in that structure, we're looking at how we would create the network components of that. In addition, we have a significant opportunity to look at different kinds of tools that would help relative to steerage to various high-value providers. Part of that in a strong primary care model like the BHCG model runs is really informing the primary care community as to where some of the stronger specialists are. You can also take that and look at it from a patient-facing tool standpoint, giving them additional information to really increase the opportunity to access and to work with higher value providers. The clear elements that go into any conversation going forward really is that issue of, can we change the payment model? Can we provide a structure that has obviously higher reimbursement for those who are performing effectively and for those who continue to progress their efficiency and their quality measures, and look at ways to have a accountability element that goes into that. The U.S. Healthcare is still heavily a fee-for-service world. We may have some tweaks around the edges around value-based reimbursements, and part of our challenge is either we've done too little or at times too much around the value-based connections. Having a additional percent increase in the unit prices because of meeting performance targets probably isn't enough to really matter. On the flip side, going to full capitation models that frankly have resulted in various healthcare organizations trying to cherry pick patients isn't a good structure either. So a ton of opportunity to go forward to take results like this to really reimburse for what matters and what's making an impact is an opportunity probably not to be missed. The last piece of the conversation, I think that fits in this dissemination of results here, starts with things like we're doing today, making sure that the information is available broadly, that it is publicly exposed. This is never intended to be something that is stuck into a proprietary bucket and we tell people they can't get it. Frankly, this is intended to be information that is broadly shared. Part of the commitment that we from the BHCG side made in commissioning the study and having Gates Ventures come on as a primary sponsor was to publish study results in a peer-reviewed journal or journals. My guess is, given the interest, we may have multiple opportunities along those lines. So it will be put into the medical literature. We also have a number of entities that have reached out relative to bring some of these ideas into their world. So other employer coalitions across the country, obviously interested in this result and looking at the potential for replicating it elsewhere. Excuse me. Some of the other states that have all payer claims databases have been participating in these calls, looking at opportunities for them to do some of the same kind of work. I think we have a resource across the country in APCDs that have probably been underutilized. And this is an opportunity to take the really robust data they have and to take it out into a broader connection to their marketplaces. Similarly, some of the foundations that are in existence around the country that look at the promotion of different kinds of value-based opportunities have been interested in this set of results. I think we will continue to work with those organizations and certainly value the outreach we receive from them. And we've also started to get some outreach from just the broad-based media who are interested in this. And so you all may see some articles that come out of this that are more broadly consumed. So our expectation is that we're going to get a continuing dissemination of this in a number of different venues. You'll probably see more of this as we go forward. With that, I'm going to pull up and see what kinds of questions we may have. Again, if you'd like to ask a question, please go ahead and put it in the chat. I will make sure that it is repeated, and then we'll address it as we go forward. We've done sessions both Wednesday and Thursday and had some questions that came up from there. And I think a couple of those were interesting and bear repeating. So I may start with those and then see what we get from this group. One of the initial questions we got in the Wednesday session was from the employer side, which said, what expectations should we as employers have as to what health systems would do with this data, and what is reasonable, both looking back at what has happened and what could potentially be done going forward in accelerating that process. I know that a number of the health systems in the state did in fact acquire the version 2.0 data from WHEEL. That does give them access to look at literally the individual by individual physician performance within their health system or their physician practice. I think that was a great starting point. We would have liked to see, frankly, a little more incorporation of that into some of the ongoing day-to-day activities that those groups were putting on together. I think it was sort of a initial question of how do we take data like this, which is pretty rich and pretty extensive, and make it actionable within our organizations, and having the comparative analytics and being able to go back to simple questions like I've got 6 physician practice who work side by side, and I'm seeing highly variable results and how some manage their diabetic group, for example. So I've got some really good diabetes managers and some who are struggling with it. What does that mean? How should I do things differently? Part of the interesting observations that we heard out of some of this is, maybe we just need to spend a little more time having our physicians talk to each other and to really look at what one is doing differently than the others. Our healthcare community, and part of that is the misaligned incentives. When the structure is all about productivity and payment for transactions, you lose some of the richness of the dialogue back and forth. Going forward, we think there's a huge opportunity to use this data. Dr. Steinberg, I'll ask you to just touch on some of your thoughts as to what you would do if you were running a clinical practice and might take some of these results to make an impact.
Thanks, Dave. There are a couple of things that I would mention. Both that I think the healthcare providers could do and should do, and some things that payers and employers could or should do. On Wednesday, after the presentation, an orthopedic surgeon who's the chief medical officer at what apparently is a very large orthopedic practice in Wisconsin, talked to me about things that they have done. And among them are things that I've observed earlier in my career. I spent a number of years at the Geisinger Health System in Pennsylvania, and which is very highly regarded with regard to quality of care. But let me give you some examples of where there's waste and where there are things that a system could do that would increase the efficiency of care. So this orthopedic surgeon talked about the variation in the artificial joints that the orthopedic surgeons in this group practice use when they're performing either total hip replacement or total knee replacement. And it may surprise you that there are thousands of dollars difference between artificial hip type 1 and artificial hip type 2, but there's no difference in the safety or effectiveness of those prostheses. And so he went and had a conversation with physicians who were using the most expensive, where he knew there was no difference in the performance of the joint replacement, and asked, why do you use this joint instead of this other joint? The physician's response was, I like that supplier's rep. So that's not something I think payers, employers would view as a valid justification for spending, thousands more on each of these joint replacement surgeries. Another thing, another instance that I've observed is that some orthopedic surgeons use joints preferably they prefer to use joints that they used when they were in their training. But there are newer joints that are equally good or better and much less expensive. So again, Dave's comment about more conversations between docs, this is an instance where I think leadership, medical leadership in a health system or a practice ought to expend effort. In terms of what employers or probably employer groups can do, I would encourage BHCG, one or more representatives of BHCG to go out and talk to major health systems in Wisconsin and ask them if they have made the effort to acquire this data. And if not, why not? And also, if not, what do they do to look at quality of care across different physicians and cost of care? And I don't know what type of responses they get. I don't know what the health systems here do in terms of that, but I can tell you that at Geisinger, they made a significant use of their EMR to quote unquote incent docs to do the preferred practice. And they had doctor groups, leadership get together with other docs in a particular specialty and define some things that they thought everybody ought to do. And then they had some IT people go in and program their EMR so that doing that was the easiest thing for the doc to do. And doing something different was harder, took more clicks, took more time. And so that's an incentive to do preferred care. Also at Geisinger, all the docs were employed, and their compensation depended on their performance on various quality measures and their compliance with what their own docs had said, had agreed were preferred practice. So those are examples of things, but doing nothing is not going to change the results going forward.
Thank you, Earl. I'm going to pick up a couple of the questions that have come in. One of them, I think, really comes back to how you take data like this that sits in a large data repository and make maximum most effective use of it. And the question really comes back to, with all the different contractual relationships and contracting structures that exist in the state, are you comfortable that you can normalize the data in a way that is really effective? Is there a use of things like, relative value unit comparisons or other kinds of underlying utilization structures that would allow us to make sure that we are on an apples to apples basis? I'll give you my thoughts and then probably ask Earl to correct me when I get it wrong. The use of normalized cost helps with some of that, and gives us the ability to get away from some of the structures that have popped up that provide things like different kinds of payment models that have various outlier protections and things like that try to get at the unknownness of healthcare. But it also raises a fundamental sort of chicken or the egg question, which is, if you change a payment model, does it change behavior, or should you get the behavior first and then reallocate your payment model to reimburse for the kinds of behavior that you're shooting for? It is an ongoing conversation that happens, I think, in how you use those results. I think, Earl, we feel comfortable. We've at least, sort of taken into account to the maximum extent possible things that may be generated by the different contracting structures that sit in the data, and at least have, taken out things like the obviously dictated price that sits under a Medicare, RVRVS schedule versus a negotiated price that sits in a commercial contract. But I think there's, it's an important piece of the conversation. Any additional thoughts on that part?
Well, a couple of thoughts. One is that what's referred to as bundle payment is a form of reimbursement that incents efficient delivery of care and elimination of use of services, a reduction in use of services that aren't really needed. So, for example, a fixed amount would be paid for a total hip replacement if there was a bundle payment structure. And I don't know how many of the insurers in the state use that type of risk-based payment. The other thing is that health systems shouldn't worry about the complexity of this data. What WEO can provide is the final results that could be delivered in table form where the a row for a doc would have their quality of care in one column, their cost efficiency of care in another column. And it can also deliver information on, well, what was the EBM with which Dr. Jones didn't comply? And if that happens to occur frequently in the case of one EBM and not another, for a particular doc or all the docs, they can have a conversation with the docs and look at, have a discussion about why is this? Why are you not doing this? That type of thing.
Thank you. I'm going to pick up another question that came through, which was, boils down to when is this data going to be more available at the health system level? And then how is it going to be incorporated into the existing BHCG Centivo network configuration? We've had Dana Richardson from WEO the last couple of sessions. She's committed that to the extent that the provider community is looking for this data, she will, similarly to the past study, make that available to WEO members, and has a structure that has been set up for you to participate as a WEO member strictly for this element, using what she has described as the physician value scorecards that she's made available. So that information should be available, I think, probably third quarter, maybe early fourth quarter of this year. Similarly, on the timing, the BHCG Executive Steering Committee will be looking at these results over the next month or two, really drilling deeply into what the results are showing and being able to look at what that might mean from any kind of adjustments in network configuration. I think that the steering committee has been pretty close to the development of these as we've been going along, and is really looking at creating a network structure that is really does three things. One is we don't want to be in any way needlessly disruptive to what's existing in the current model, and so things like seeing the really strong consistency of performance for those who are identified as high performers is really valuable. To the extent that there needs to be adjustments made, those will likely be made effective for 1/1/26 plan years and going forward. So it is not trying to race to a change that's hard to accommodate. The other thing that BHCG has frankly said all the way through is we want to make sure that we communicate with the health system partners that participate in the high performance program in a way that gives them information and understanding of what it is before any changes are made. So there's an obvious point of dialogue that will happen likely towards the later part of the summer or very early fall that gives that information so that everybody has the ability to incorporate it into their planning going forward. And employers can obviously structure their benefit programs in a way that makes sense for 1/1/26 and later. Jennifer, the other questions that have come in? All right. Well, with that, I'd like to just add a few additional words of thanks in all of this. First, I'd like to thank the New Berlin School District for allowing us to use their room and their AV capabilities here, and appreciate their technology staff in supporting us, because I would tell you the two of us who've been speaking will probably be completely overwhelmed if we had to do this ourselves. So thank you to the staff here for helping us with that. Again, thank you to the co-sponsors who really got behind this study and provided the financial resources to make this happen. This is not a small undertaking. It has a meaningful financial commitment to it. And those co-sponsors were invaluable in making sure that we can push this forward. I'd also like to thank all of you who've taken your time to attend this session, and hopefully you got some really good information out of it. As we noted earlier, the slides and the recording will be available on the Business Healthcare Group website, which is bhcgwi.org. Yeah. Please feel free to go there. We'll get that posted relatively quickly. Again, at the end of the day, this is all about sharing and transparency. This is not about finding it hard to get information out to people. So we look forward to getting a lot of people to access that information. And as Lisa noted early on, the ability to get any kind of questions answered and any other elements, you can contact anybody at the BHCG steering committee or directly into the BHCG website, or to Jennifer or me, and we will circle back to you on any additional questions you may have. So again, thank you for your attendance today, and hope you all have a good weekend. Take care, everybody.